Good morning, respected Ishwar sir, President of Arthroscopy Society of Nepal, and Dr. Sailaj Ranjitkar sir, the Scientific Chairman of Arthroscopy Society of Nepal, all the seniors and colleagues. Today we are going to talk about high tibial osteotomy. Osteo means bone and tomy means to cut. So osteotomy is a technique in which normal bone is cut and realigned so that the new alignment of the bone is achieved. Osteotomy is not a new technique or new art. It is relatively older technique, and it was very popular back then. But because of popularity of total knee replacement, the high tibial osteotomy was gone into disrepute. But because of development of various alignment principle by Dror-Pelly and all, what happened is the high tibial osteotomy has come back with a bang, I must say. And nowadays there is a trend towards opening wedge high tibial osteotomy. And today we will be discussing about this very technique of high tibial osteotomy, right from its terminologies, right from its technique types, and from up to relief surgery. So high tibial osteotomy was already discussed. One webinar of high tibial osteotomy has been already conducted by Arthroscopy Society of Nepal under the active leadership of Professor Amit Joshi, where we had Dr. Santosh, Dr. Clement Joseph, and Dr. Pranjal Kotkani from India as our faculties. They taught us a lot about the high tibial osteotomy. So this time we attempted to venture about this particular topic by ourselves. Today we have Sudeep Mansrestha talking on evaluation of limb alignment and about the terminologies used. Then Susil will be talking about type of high tibial osteotomy, indications and contraindications. Then I myself will be talking about pre-operative planning. And finally, we'll be wrapping with Professor Amit Joshi talking about relief surgery of high tibial osteotomy. So let's learn together and let's start the meeting. Yes, sir. Now it's...
Yeah?
Yes, sir. Your screen is visible, sir, and you are audible as
well. Okay. Good morning. Good morning, everyone. Today, I'm very happy that apart from the arthroscopy, we have trying to present we have selected a topic evaluation, higher tibial osteotomy, which was once forgotten technology. We have been trying to use it, and we have noticed that it has a lot of application even till now. I have been giving the topic of evaluation of the limb alignment and terminologies used. Hello, am I audible?
Yes, sir. Loud and clear.
Thank you. Now, in this headline, I would like to add one more terminology. It is not your evaluation of the alignment. It is the limb evaluation of the limb alignment. We have to add one more topic terminology like limb. The joint orientation is also important in this headlines. So I'll go further with that. So for deformity correction, whether it is around the hip joint, shaft, supracondylar area, or higher tibial osteotomy, or around any ankle joint, we should consider two things. Alignment refers to the collineary of the hip, knee, and ankle joint. That means we are correlating overall alignment of the limb. That is from the hip joint to the knee joint and the ankle joint. But only aligning limb itself is not good enough. First, to have the proper outcome, we need to have a proper joint orientation also. So joint orientation refers to the position of the articular surface relative to the axis of the limb segment. So it may be mechanical axis or anatomical axis. So this is a joint orientation. Usually for the ankle joint, it is very obvious. It is usually parallel to the ground and we refer to the axis of the limb. When for the knee, it is more obvious. But for hip, usually we feel the hip is a round joint, so it is not obvious. But it is also, it also has a joint orientation. Usually it is from the tip of the retrocanther to the tip of the hip joint. Sorry, center of the hip joint. Why we should, whenever we correct any kind of deformity, it is not only high tibial, why we should know this? Because whenever we look at the limb, whenever we look at the X-ray of a patient, there are a few questions we must ask ourselves. Is there any deformity? If you try to say this, we have to ask question, is there a deformity? And where is the deformity? And is it in the femur? Is it in tibia? And if we have to correct it, where do you need the correction? So to know where is the deformity, first we have to know the normal. Only when you know the normal, because even normal there can be a little variant, then we can measure the abnormal. So today I'll be mainly talking about the normal alignment and the various terminologies used. Most of the reference I have taken from the book of Drawer, for the famous Drawer Palais. Let me see the nomenclatures. Many times we find it, and those angles we find it very cumbersome and very confusing. Today, let's see. I'll try to clear most of the doubt, and I hope at the end of this session I'll be successful. Thank you. So let me show you one X-ray. If you look at this limb of this 25-year-old lady who comes with the pain of the knee joint, if you see his overall limb alignment, if you will say it is more of a, it's okay, like, it doesn't look so bad. But if you, the same X-ray, if you see, anybody can comment? Dr. Vivek, would you like to comment with this?
Sir, I think there has been some surgery in his maybe left distal femur, and the joint orientation is not right. There is the joint alignment is not right there.
Now, if we see the alignment, it is not so bad, because if you see the alignment from the center of the hip to center of ankle, it is a little bit of deformed, but there is a definite obvious varus of the hip joint and the valgus deformity of the knee joint. These are the compensatory. So though the alignment, that's why I said in the beginning, it is not only alignment is necessary, it is the orientation of the joint also necessary for the overall correction of the knee. Otherwise, if you only correct the alignment, and if you do not correct the deformity, and if you do not find out where the deformity is, the overall alignment correction may not be right enough. You're right. So if we see, then once we start drawing these lines, we'll come to know at the end of this talk. Then we know where the deformity. In this particular patient, deformity is not only in the knee joint, it is also in the femur. Deformity in the distal femur and proximal tibia, there is a deformity. So that's why we have to know overall calculation, degrees, and the deformities. So for complete correction, for complete assessment of the limb, we have to know few terminology. These are the limb alignment, mechanical axis, anatomical axis, joint orientation line, and joint orientation angle. Let's go one by one. Limb alignment or mechanical axis. It refers to the collineary of the hip, knee, and ankle. Once you draw a line from the center of the hip and center of the ankle joint, many times it passes from the center of the knee, but most of the time it is a little medial to the center of the knee joint. The long bow has two axes. One is the anatomical axis and another is a mechanical axis. So we need to evaluate the bones in both the planes, that is in the frontal planes and lateral planes always. So mechanical axis is defined as a straight line connecting the joint center of the proximal and the distal joints. The mechanical axis is always a straight line, whether in the frontal or sagittal plane. So let us see the mechanical axis of femur. It is, when we draw it, it is from the center of the hip and the center of the highest point of the notch. It is the mechanical axis of tibia. It is the center of the knee joint between the two the tuberosities, and at the center of the ankle joint. When we draw a line, this is the mechanical axis of the tibia. Anatomical axis of bone is usually mid diaphyseal. It is usually we don't calculate from the top. It's a mid diaphyseal line. The anatomic axis may be straight in the frontal plane, but it can be curved in sagittal place, as you see in femur in this case. So how we draw is usually mechanical axis is drawn at the midpoint of the cortex at two segments, usually at the around middle third. So if you see the closer view, in the femur, the midpoint of the cortex at two segments, and if we draw a line, usually in the higher up, it passes around the piriformis fossa of the hip joint, and below, it is not exactly in the center, as we saw in the mechanical axis. It is around the little medial to the femoral notch. But in case of deformed hip joint, it may not always cross from the piriformis fossa. So this is one point we have to remember very clearly, that for the anatomic axis, we are drawing from the cortex, from the midpoint of the cortex. So for anatomic axis of tibia also, when we draw it, so it is from the midpoint of the cortex, and higher up we go, it is not exactly in the center, slightly medial to that. Even in the ankle joint, in the mechanical, it was exactly in the center. Now it is a little slightly medial to that. So overall, when we compare the mechanical and the anatomical angle of the femur and tibia, in the femur, it is around, when you compare mechanical axis and the anatomical axis makes the angle of around 7 degrees plus minus 2. Whereas in tibia, in the most of the time, it is parallel. So that is why whenever we do any correction, whether it is a hip joint replacement, knee joint replacement, or any kind of deformity correction in the hip joint, we have to consider this angle. And in the most of the time, the tibia, since it is being a parallel line, we are dealing with the more or less same axis. Alignment and orientation, mechanical tibiofemoral angle, if you see overall, or the anatomical tibiofemoral angle, it is usually, mechanical tibiofemoral angle is around 2 degrees, 1 or 2 degrees of varus, and anatomical tibiofemoral angle is around 6 plus minus 2 degrees of varus. That is why when we draw a line, when you take a limb alignment or limb alignment axis from the tip of the center of the hip to the ankle, it is exactly not in the center of the knee joint, but slightly medial to that. Malalignment occurs when the center of the joint does not lie close to the mechanical axis of line. As it goes further from the mechanical axis, there is a deformity. The distance between the mechanical axis line, so mechanical axis distance, and the center of knee joint in the frontal plane is the MAD. MAD is described as either varus or valgus. If it goes towards the medial side, it is varus. Goes lateral side is valgus. Now we are talking about the joint orientation line. I had shown this figure before also. Usually it is obvious, it is the overall orientation of the ankle joint, knee joint, hip joint, in reference to the surface of the ground or in reference to the mechanical or anatomical axis of that bone. So in the ankle, it is very obvious. In the knee is obvious, but in the hip joint, it is usually round joint, but we are taking again from the reference from the tip of the greater trochanter to the center of the hip. How we draw these planes? In the hip joint, from the center of the tip of the greater trochanter to the tip of the hip joint. And the hip, we have to draw two lines. So here, so this is very, very essential, even not only this osteotomies, even when you do the hemiarthroplasty or the total joint replacement, we usually try to match this from the tip of the greater trochanter tip. If it goes down, it becomes varus, or it goes up, it becomes valgus, and overall correction may not be right, and you may not get a very good long-term result. Similarly, we need to draw angle from the separate center of the hip joint to the mid shaft of the neck. This gives a neck shaft angle. Even the hip, we have to take care of this angle also. In the knee, how we draw this plane is in the tibia, usually the most convex part of the tibial plateau. We draw lines, the medial and lateral side. In the femur, it is the most convex part of the femoral condyles that gives a plane of the joint. In the ankle joint, it is the lowest part of the tibial, the tibial plafond. It is here, the lowest part of the articular surface. Usually it is. And in the lateral view also, in the sagittal plane is the most prominent part of the lower end of the tibia. So this gives the overall joint orientation of the ankle joint. In the sagittal plane, sorry, I don't know why it's changing so fast. As we saw, in the knee joint, the lateral usually the most prominent part of the tibial plateau is taken care of. This is drawn like this. And in the femur, we consider when the epiphyseal is not fused, it is the anterior and posterior epiphyseal point. From there, we have to draw a plane. But when in the adult bone, when it is fused, usually you find some epiphyseal scar. If you see most of the X-rays in adult also, you find some epiphyseal scar, you said, and you have to draw a line from there. So now we come to joint orientation angle. It refers to the position of articular surface relative to the axis of the limb segment. So how it is drawn? The angle formed between a joint line and either the mechanical or anatomical axis. Each axis line and the joint orientation line intersects and forms a two angle. Either angle could be named with the nomenclature. So usually many times we see a lot of nomenclature, you find it very confusing. I've taken all this reference from the Drode-Pallis book, and the name of each angle specifies whether it is measured from the mechanical or the anatomical axis. The angle may be measured from the medial or lateral and the position of the axis of the limb. The angle may refer to the proximal, distal orientation of the bone. Either F refers to femur or tibia. Let's see one example. Okay, if you see this angulation, if you see now the angle around the knee joint in the femur, it is lower distal femoral angle. If we just say LDFA, it is maybe a little confusing. But if you say lower distal femoral angle, it is around 80 degree, and M refers to, as I say, it refers to mechanical. Okay. If you come here, MPTA, it is 87 degree, is a medial proximal tibial angle. I think I have made it clear. if you go here, this is in reference to the anatomical axis. This is again lower distal, I don't know why it is so sensitive, lower distal femoral angle, and that small a refers to the anatomical axis, and the middle side is more or the same. And this line is joint line congruous angle. This is around usually 0 to 2 degree. In the frontal plane, what are the angles? We know it. In the around the hip joint, the plane of the hip joint with the mechanical axis, it gives a LPFA, that is around 90 degree. It ranges from 85 to 95. This is again LPFA, lateral proximal femoral angle. Now it is, if you try to use the terminology, these things are not very difficult. This I already showed it. Mechanical axis, lateral distal femoral angle, it is around 80 degree. It ranges from 85 to 90 degree. So what happens on the medial side and the proximal tibia? Usually more or less it is the same. I think we call it in geometry, if I know a little bit, is this called isosceles triangle? Just correct me if I'm wrong. So it is also now medial proximal tibial angle. It is 87. So this more or less same. It varies a little bit because of this joint line congruent angle. Now we go further. In the distal part, now LDTA, what is this? Again, very simple, lower distal tibial angle. It is around, 89 degree. So now we come to the anatomical. Anatomical, what are we referring with that? Let's go around the hip joint. So this is when we make angle between what's happening? Now, medial neck shaft angle, that is between the axis of the neck and the anatomical axis of the femur. And another is when it is made with the joint plane, medial proximal femoral angle is around 84 degrees, is 130 degree. When you come to knee joint, when it is taken with the reference to anatomical axis, it is LDFA, anatomical lower distal femoral angle. It is 81 degree, as we know. Because the anatomy, why it is 81 degree? Now it is very obvious, because in mechanical axis, it is, and the difference between mechanical axis and the anatomical axis is around 7 degrees difference. So now it was 88 in the mechanical, with reference to mechanical axis, and with reference to anatomical axis, it is now 81 degree. In the proximal tibia, medial proximal tibial angle, it is around more or less same. And same, the joint line congruence angle also remains the same. When you come to ankle joint, it is lower distal tibial angle. So it is around 89 degree, which ranges from 86 to 90 degree. So all these numbers are a little confusing, but if you really try to know the anatomical part and side of the medial lateral, these things are not very confusing. And if you keep on practicing it, it doesn't become so difficult. But these angles are very, very important. Whether you do any correction around the hip joint, knee joint, or ankle joint, we must take the reference of these angles. In the sagittal plane also, around the hip joint is the anterior neck shaft angle around 170 degree, and posterior proximal femoral angle. Actually, these abbreviations are not very difficult when you really try to define it. The knee joint again is lateral. Posterior distal femoral angle, it is around 83 degree, ranges from the 79 to 87 degree. And posterior proximal tibial angle, it is around 81 degree. In the ankle joint, anterior distal tibial angle is around 80 degree. So overall, I think I have tried to cover most of the nomenclatures. So take home message is limb alignment and joint orientation must be considered before planning any kind of corrective osteotomy. And we must know the normal values and the measurement of the opposite limb while assessing any kind of deformity. So I hope I tried to make all this terminology clear. So if you, the Albert Einstein says, if you can't explain it simply, you don't understand it well enough. So I hope I have made these things clear. Let me hear from others whether I have made my things clear or not. Thank you very much.
Thank you, Sudeep sir, for such a wonderful presentation. I think we all have understood this complex terminologies which usually are being used when planning high tibial osteotomy. So if any questions, I think we can take one or two questions. Sushil, are there any questions in the chat box?
Well, I don't see one in the chat box.
Okay, Sudeep sir, if you can unshare your screen, sir.
Okay. Okay.
Okay. So our next, I think there are no questions at present in the chat box. So I think we will go on. With our program. And next talk is from very dynamic surgeon, Dr. Sushil Thapa. He will be talking about types of high tibial osteotomy, its indications and contraindications. Thank you.
Thank you very much, Vivek. Namaste and a very good morning. I'm Sushil Thapa from Bharatpur Hospital, and my talk is on high tibial osteotomy, their types, the indications, and contraindications. Well, it's a quite straightforward presentation. I think it's a very short presentation and very few slides. Let me begin with an important concept given by Fujisawa. He divided this tibial plateau from medial to lateral into different portions, the middle portion being 50%. And he defined one more point at about 62.5% from the medial tibial plateau. And this is the weight-bearing line he defined. So weight-bearing line passes through this point. This is not the middle, but this is rather slightly towards the lateral. And this is slightly towards the lateral tibial spine. This is the lateral tibial spine. So slightly lateral is the weight-bearing line. And this is also called Fujisawa point. And this is the weight-bearing line. And Vivek, in his next presentation, will explain why this is important and how to calculate this. And the basic idea of high tibial osteotomy is to offload the medial compartment. This is the, in abnormal cases, this is the line through which the weight passes. And because of this factor, the cartilages of the medial compartment has been worn and torn out. So in order to reduce further wearing and tearing of medial compartment, or in order to regenerate few amount of cartilages in this medial compartment, we want to offload this medial compartment and now take the weight bearing axis towards more lateral, so that offloading a medial compartment reduces or prevents further deterioration of the cartilage damage in this portion. Not only of the cartilage damage, but for other procedures as well. I'll explain in subsequent slides. So this is the mechanical axis, and tons of other axes have been very well defined by Sudeep sir. To be very brief, there are several types of high tibial osteotomy. The most common one being medial opening wedge osteotomy. Others are lateral closing wedge osteotomy, dome osteotomy, and progressive callus distraction osteotomy, and chevron osteotomy as well. Out of all these osteotomies, the most common is medial opening wedge osteotomy. And maybe most of us, if not all of us, have either seen or assisted the medial opening with osteotomy. So let me define in short how what is medial opening with osteotomy, how this is done, a very brief presentation. This is a Fujisawa point here in this X-ray and also in this sketchy figure. Let's draw one line towards the center of the femoral head. Actually, I need a whole scanogram for calculation of this line, which shows the femoral, which shows the hip joint right up to the ankle joint. And let me draw another line towards the center of the ankle. Now, if I extend this line proximally, and this is the angle, let us suppose this angle is 10 degrees. Now, this is the correction I need in this varus deformity. Now, I want this line to pass, along the red line so that the axis points towards the femoral head, and we can achieve the axis, desired axis, as Sudeep sir was trying to say. Now, how this can be achieved? There are several methods of achieving this, and one of the commonest methods of achieving is medial opening with osteotomy. About 4 centimeter distal to the medial joint line, we draw one line. It's a reference line. It can be identified with the help of a K-wire and seen under fluoroscopy. And I take another line, and I want to distract this cut portion, osteotomized portion, distally, so that the angle made is 10 degrees. And after this much portion is distracted, now this line is going to overlap against this line, and the correction is achieved. This is a very simplified actually, and there are other, it should be cut in other planes as well. The subsequent presentation will clarify this to a larger degree. And this is an oblique line extending towards the tip of the head of the fibula. And this portion is distracted. And if the gap is more than 1 centimeter, we may need bone graft, or there may be other parameters as well. So this is how this is done. And the advantages of medial opening with osteotomy is the single osteotomy is enough here, and there are no neurovascular complications because we are going well above the neck level of the fibular neck. So there is less likelihood of the neurovascular injuries in these medial opening with osteotomy. And in case we need fusor total knee replacement, we have a good amount of bone stock in these proximal tibia, which is necessary for fusor total knee replacement surgeries in case the patient needs one, because this is one of the surgeries to delay the total knee replacement or to buy time for the total knee replacement. And there is no limb shortening in this medial opening with advantages. But of course, some disadvantages come along with the advantages. There is some chance of non-union, and the wood bearing period is long. This is longer as compared to the lateral closing with osteotomy. And the leg lengthening may be present. There is no shortening, but leg lengthening may be present. And the posterior tibial slope may increase, and this may have some effect on the mechanical aspects of the anterior cruciate ligament as well. Now, this is ideal not for all the patients. This is ideal for if there is more than 2 millimeter of leg length discrepancies in case of PCL tear, and in case of MCL laxity as well, because we peel off the MCL here at this position and try to distract the bone. So if there is some laxity, this is going to correct the degree of laxity once the MCL heals in the new position. And if there is patella alta, then this is going to pull down the patella after we distract this amount of bone. So this is going to correct the patella alta as well. So these are the ideal candidates. But if the patient is a smoker, if he's obese or he's been taking steroids, which make the patient more vulnerable to non-union, this may not be ideal. We should think of some other modes of osteotomies. Another is lateral closing with osteotomy. This is the same calculation here. Now I want to close by 10 degrees, the lateral portion. In this case, there is less, This is 10 degree, let us suppose. This may be 15 degree or this may be 8 degree. And this 10 degree of bone is removed from here, and this portion is closed. In medial opening wedge osteotomy, we open this portion of the bone here on the middle aspect, while in case of lateral closing wedge, we are closing it. We are removing this bone and we want to close it so that the angle gets corrected. There are advantages. We can correct it at maximal point of deformity. Suppose this is the maximal point of deformity, we can correct it, and there is rapid bone union, because this is the metaphyseal portion in lateral closing wedge. While in opening wedge osteotomy, we started from almost from the metaphyseal diaphyseal junction. So comparatively, this has better chance of union. The union rate is rapid, and the patient can be advised for early weight bearing, and the rehabilitation, which is very important after surgery, can be started earlier. And the loss of correction is less likely here because the union is rapid. So we are not going to lose correction as compared to the middle opening wedge osteotomy, where the union rate may be delayed or maybe less. And of course, there are certain disadvantages that come with this. The fibular osteotomy may have to be done. So there are 2 osteotomies required, unlike in the middle opening wedge. And neurovascular complications may occur because this is the area where the fibular, where the common peroneal nerve passes. So we may encounter with the neurovascular compromise, and limb shorting may be present. And in case of future total knee replacement, the stem may impinge here, because this goes this way towards lateral. So the stem of the prosthesis may impinge on the medial cortex. So this is undesirable. And one more advantage here is we can even see the joint line if you make the incision long enough on the lateral aspect. That is the advantage. So this is ideal for diabetics, smokers, and steroids because they run the risk of non-union. And since this is the metaphyseal cancellous portion, there is better chance of non-union. So if you have to choose in between the medial opening and the lateral closing wedge osteotomy in these patients, then we should opt for the lateral closing one because the union rate is higher. And in case of patella baha, this is better. This can address the patella baha as well, because this is going to take the patella upwards, because it makes the patellar tendon slightly lax. So the quadriceps is going to pull the patella upwards. So these are the ideal candidates for the lateral closing one. And there are other osteotomy techniques as well. This may not be so popular, but if you want to achieve higher degree of correction, then these are the better alternatives. This is the dome osteotomy. We make the osteotomy so that the distal portion up here assumes the shape of a dome, and this can be corrected in all the planes, the mediolateral plane or the anterior posterior plane. And there's another called progressive callus dissection osteotomy. If we need the correction of more than 20 millimeters, then we make the osteotomy here and put the external fixator in the form of the Elizarov or the conventional ones, and we can gradually distract over time, over days, until we get the desired amount of correction. But this is more cumbersome as compared to other modes of osteotomy. So this is not so commonly practiced. And another is Sebron osteotomy. This is the inverted V. We make a V-shaped cut, and the V-shaped cut, the wider portion is taken to the other side around so that the deformity is corrected. Again, this portion, this is the one of the least popular one. This is more popular in other parts of the bone, but least popular in proximal tibia. And there are a few important indications of high tibial osteotomy. One of the commonest indications we've been seeing and we've been performing is varus malalignment in osteoarthritis of the knee, because if the middle compartment osteoarthritis is present while the lateral one is intact, then we go for this high tibial osteotomy, because we want to offload the middle compartment and take the load toward the lateral compartment. This can be a time buying for future total knee replacement. And in case of meniscectomized knees or in any procedure like meniscus implantation, allograft of the meniscus, which is being more popular these days, Suppose we have transplanted the meniscus here, or we have performed some procedures on the meniscus here in this medial compartment. Now, we don't want any more load along the medial compartment, so that the meniscectomized or the transplanted meniscus is not going to have more ill effect. Now, in that case, we want to shift the loads toward the medial compartment, and this is one of the indications. And chondral resurfacing, for example, mosaicoplasty or autologous chondrocyte implantation has been done on the medial compartment. Again, we want the load to shift towards the lateral compartment. In this case, the high tibial osteotomy is also indicated. In case of chronic ACL deficiency, sometimes just performing the osteotomy, high tibial osteotomy, can address can avoid the need for ACL reconstructions, or it may be combined with the ACL reconstructions as well. Because there are some studies that say even high tibial osteotomy alone, without performing reconstruction, is going to offer stability to the knee. So we don't need the ACL reconstruction. And correction of the posterior tibial slope, which may be required in the chronic ACL tear, or which may be required in other deformities as well. But of course, there are certain contraindications of high tibial osteotomy. If the joint destruction is very severe, not only the medial compartment, but also the lateral compartment has been affected, then this is not a good candidate. This is the Albright grade 3 osteoarthritis. And more than 65 years of age, he has undergone cartilage damage in almost the entire joint. We don't want this patient to undergo high tibial osteotomy. And advanced patellofemoral osteoarthritis, the patient continues to have pain despite the high tibial osteotomy. So this is of little importance, little use in case of patellofemoral osteoarthritis. If the range of motion is less than 90 degrees, very poor rehabilitation, and this is not again a good candidate. And if more than 15 degrees of flexion contraction, we are not going to achieve our goal in this case as well. So we don't want to perform STO in this case. If there is joint instability, more than 1 centimeter of the lateral tibial thrust. If there is lateral tibial thrust, then even after performing the high tibial osteotomy, the cartilage damage keeps going on, and the load cannot be shifted, at least in the stance phase of the patient, because in stance phase, there is going to be a lateral tibial thrust, and load again passes through the medial compartment. So this surgery will fail in case of joint instability. So the stability has always to be addressed before we perform the bony procedures. If there are ligamentous instability, they have to be taken at the same time or before or after the bony procedure. And if we need more than 20 degrees of correction, then this is not advisable. High tibial osteotomy is not advisable. So and body mass index more than 30%. So obese patients are contraindicated. They are very poor candidate for high tibial osteotomy. So this is a very brief theoretical portion of the types, indications, and contraindications of high tibial osteotomy. And further image will be clear, the picture will be clear in the next 2 subsequent presentations. Thank you very much.
Thank you, Sushil, for such a lucid presentation. It's always delight to watch your presentation. So, so there are 2 questions that poured in our chat box. One is from Amit sir. His question is, does JLCA has any role in deciding angle of correction? So JLCA, joint line congruence angle, does it have any role in deciding angle of correction?
This is for Sudeep sir or myself?
This is for you, I suppose.
Joint line congruence angle has a role in deciding angle of correction. Yes, as shown by Sudeep sir in one of his earlier example, where some procedure was done in supracondylar femur on the medial aspect, the joint line congruency was not maintained. So just maintaining the axis is not going to address the deformity. The joint line, of course, has to be corrected.
Absolutely. Sir, Amit sir, are you okay with the answer? Or if not, please come in and Please ask the question yourself, sir.
No, I think Sushil very correctly mentioned joint line congruence angle is very, very important, and it has to be subtracted from the total correction when you start, planning your exact correction of high tibial osteotomy. It has to be subtracted so that your joint line angle should always be maintained. That is why one of the reason why, if it is more than 15 degree of angulation that has been corrected only by high tibial osteotomy, your joint line starts, angulating. So joint line doesn't remain parallel, it becomes more oblique. So that is the reason why if you have a higher degree of correction to achieve, then probably you have to do both tibial as well as the femoral correction. That is why joint line congruence angle is so important.
Okay, absolutely. Thank you, Amit sir. So next question is, I think it is again to you, Sushil. It is from Dr. Manoj Kushwaha. Can closing ways correct JLCA, and how to decide which osteotomy to choose?
Yes, Manoj, I want to derive the answer from Amit sir's statement, which he said just now. If closing ways, we have to calculate, subtract the angle from the congruency, joint line congruency, so that we can address the congruency as well. And if the osteotomy in one side is not sufficient enough, then we have to choose the osteotomy, or we have to supplement this with osteotomy at another side as well.
So his second part of question is how to choose whether to do open ways or closing ways in any particular case.
Yes, there are a few ideal candidates for opening ways or closing ways osteotomy. They have their own advantages and disadvantages. If there are risks of non-union, then we should go for the lateral closing ways osteotomy, like the smokers, diabetics, or the obese patients. And if there is limb length discrepancy, then we should go for the lateral closing ways osteotomy. On the contrary, if there is there are no risks of non-union, then we should go for the opening wedge osteotomy. And if you want to correct the posterior tibial slope as well, then the middle opening wedge is more ideal.
Okay, thank you, Sushil. That was wonderful answer. So Devendra Acharya asks you, does high tibial osteotomy has any role in PLC tear?
Well, it has some role in the ALC and posterior cruciate ligament, but regarding PLC tear, I cannot comment. I have no idea about that.
So I think there is some role in PLC tear, not in acute setting, but in chronic setting, I think, because it usually occurs when there is simultaneous injury of ACL or any intra-articular cruciate ligaments along with the PLC tear. PLC is neglected or PLC is missed. What happens is ACL is failed, and what happens because of that, there will be chronic valgus thrust gait. If patient has already developed valgus thrust gait because of neglected PLC tear, then there is certainly a role of high tibial osteotomy in that case. I think Amit sir, Ishwar sir, and other seniors might highlight in this issue as well. This is very important question, I guess.
I think this is a very important question, and what is important, Vivek also mentioned that managing PLC, which has valgus thrust gait, alone by soft tissue or by bone correction or the alignment correction is not enough. So if it is a chronic PLC with the valgus thrust, you have to do both bony correction as well as the ligament correction.
Yes, sir. I think there are no more questions left in our chat.
Dr. Vivek, I have one
doubt
about this mechanical axis. Whatever I presented today was with reference to the book of Dror-Palais, which is one of the most world authority. And at the same time, the Fujisawa point, what Dr. Sushil showed. And usually what Dror-Palais says is the mechanical tibiofemoral axis is around 1.3 to 2 degree of varus. So when the mechanical axis, when you draw from the center of the hip to ankle, usually it is slightly medial to the midpoint of the knee joint. But the Fujisawa shows the normal mechanical axis when you draw is from little lateral, which is little lateral to the midpoint.
No, sir. Fujisawa point is not the normal weight bearing line. It is the weight bearing line that the future projected weight bearing line that has. I will be discussing that in my talk, sir.
Okay. Well, this is what I thought the Sushil tried to project. This is what you are trying to correct that to that point.
Yes. I will be presenting that in my talk.
Okay, fine. Yeah.
If there are no more questions, next talk is by myself. This is about the planning of high tibial osteotomy. Sushil, is my slide visible?
Yes, we will.
Okay. So good morning, respected seniors and colleagues. Today, we have learned about various terminologies that are used in high tibial osteotomies and terminologies used in limb alignment. Then we learned about the indications, contraindications, the types of high tibial osteotomy. So I think this is now time to plan about our surgery. So I will be talking about pre-operative planning of high tibial osteotomy. So nature, the symmetry is the rule of nature, and everywhere we find symmetry. So whenever this symmetry is disturbed, there is problem. So in our body as well, whenever there is malalignment, the body has problems. So in this talk, we'll be today discussing about planning how to realign the knee and how to get the perfect balance. So I have divided my talk into 7 different headings. So first is the importance of full length X-ray and how to get it. And how is our technique to get full length X-ray in our AKB center. So second is I'll be talking about weight bearing line, which is popularly known as Mikulicz line. Then I'll be talking about the term mechanical axis deviation, some of which has been covered by Sudeep sir in his talk. Then I will talk about how to determine the source of deformity, that particular deformity, then know about the cause of deformity, then how to plan the correction, then finally how to plan the fixation. So I'll be talking about all these headings in my further presentation. So let's start with a typical scenario in our OPD. We usually get these type of patient in everyday basis. 53 years female, the middle-aged active female, complaints of pain over bilateral knee, maybe right greater than left or left greater than left. That is, she also complains of on and off swelling, and pain increases on squat and cross leg sitting. So it is so troublesome that it is impending, it is causing problem in her day-to-day activity. So what you do is you examine, there is minimal swelling, grade 1 or grade 2, maybe ligament seems okay, meniscus is plus minus, you find meniscus, the McMurray is positive, or sometimes it is negative. You ask for investigation, and X-ray shows varus knee, mainly the medial compartment osteoarthritis, and lateral compartment and patellofemoral compartment seems to be okay. And sometimes if you are sometimes you can advise MRI as well, and maximum MRI will show is degenerative tear of medial meniscus and with cartilage degeneration in medial compartment of the knee. So problem arises in these conditions because these are very usual patient. I think all of us must admit that these are very usual patients and usual case scenarios in our OPD. So what we do, some of us might advise conservative treatment. We'll ask the patient to do this, not to do that, and ask to decrease her weight, and then ask to have physiotherapy and all. And I must admit that deep down in our heart, we know that these conservative measures will not work, because these osteoarthritis will eventually progress and then cause problem in future. And if you are fanatic enough, you may ask, or you may offer replacement surgeries in these cases of about 50s patient and do total knee replacement. So problem with total knee replacement is not the panacea for every type of osteoarthritis of knee or osteoarthritis of any joint, because this total knee replacement comes with the lifespan, and these are usually about maximum 20 to 25 years or maybe 15 to 20 years. So in any lifetime of the patient, and I must admit, though I'm not an arthroplasty surgeon, the success or the survival of primary TKR or primary total knee replacement is always better than these revision total knee replacement. And revision total knee replacement are very, very costly, and they are not so much good as primary replacement. So our aim must be to have one replacement in one lifetime. So these patients, and also the total knee replacement satisfaction, I think is directly proportional to amount of degeneration in knee. In these patients, if you advise total knee replacement, these are the patients who will be lingering around you for quite long time. So what remains is the alignment surgery, which was rampantly done in the past. Because of advancement of replacement surgery, it was gone into disrepute for some time, but it has come into its life with a bang, and I must say the high tibial osteotomy is the way to go in these type of patients, if we choose the patients right. So the aim of today's presentation and today's talk is not to say that every type of osteoarthritis can be managed with the high tibial osteotomy. These type of knee, very degenerated knee and very severely osteoarthritic knee, you cannot advise high tibial osteotomy. The TKR is still the best solution for this wonderful surgery for these type of knees. So high tibial osteotomy, to have a planning of high tibial osteotomy, first and foremost, what you need is you need long full length X-ray. And to take full length X-ray, there are some technique to take the full length X-ray. So X-ray source is usually kept at the 10 feet distance, and patella is center. Whatever rotational but whatever rotation the feet has to be kept so as to have patella forward. That is, the foot may be placed in internal rotation or external rotation, but the patella has to face forward. And usually the most important thing is long 51-inch cassette. As you can see in this picture, the long cassette has been placed right from the shoulder up to the feet. This is the prerequisite to take the full length X-ray. But problem in our setting is we do not have this type of facility, and how to take full length X-ray with our common usual conventional X-rays. In our AKB center, we have been doing this. What we do is we take 3 different X-rays and we put the metal we stick some metal over the patient's body, not over the patient's cloth, but over the patient's skin, so that it won't move. And we keep these as markers in bilateral lower limb. And we take X-rays of 3, we take 3 X-rays, one hip from distal thigh, and another X-ray around the knees with proximal proximal tibia and distal femur. Then another X-ray we take about the another X-ray we take of the both legs, including the ankle. So then what we do, we paste this X-ray in our very common software, PowerPoint. We paste this photograph over the PowerPoint. We crop this photograph, we crop this picture so that we get only the X-ray part, all other part is removed. Then what we do is we Excuse me. So I think I will show this. I didn't have any control over this video, so I'm going to show this video in this windows only. There is problem with this video. So we rotate and then we crop this picture like this. We replicate this, duplicate this picture. We make first half of the right lower limb, then second half of the left lower limb. Then we duplicate them into three X-rays. Then we crop the upper part, then crop second part, and crop the third part. Then what we do is we reduce the transparency of the second part and overlap that into the first part so that the markers will perfectly overlap. Then we get back to the original transparency of the second one. Then again, we reduce the transparency of the third one, then overlap that again into the second part. So by doing so, we are getting now a full length X-ray of the right lower limb. And by repeating the same procedure, we will be getting the full length X-ray of the other part as well. So this is how we are doing in AKB center to get the full length X-ray. So after having full length X-ray, now is the time to draw the weight bearing line and find the mechanical axis deviation. This picture shows three different scenarios that can occur around the knee joint. The central one is the normal one, where the weight bearing line passes from center of hip to center of knee, then center of ankle. This is normal. And whenever the weight bearing line passes medial to the knee joint, that is varus. And whenever that weight bearing line passes lateral to the knee joint, that is valgus deformity of the knee joint. So in this full length X-ray, what we do is we draw two lines. These are the weight bearing Mikulicz line that joins the center of hip to center of ankle. And in left side, it is almost normal. And in right side, the weight bearing line there is mechanical axis deviation, that is varus. So now next step is to find out origin of this deformity. So to know this deformity, we should refer back to this very popular diagram from Campbell. There is normal angle between the anatomical axis and the mechanical axis of femur, that is about 6 degrees, and anatomical axis of whole of the lower limb, and the angle between anatomical axis and the mechanical axis, there is almost about 6 degree of 6 degree is there. And normally the mechanical axis is almost about 3 degree valgus. So this is the same picture that Sudeep sir has shown from Dorpally picture, and the mechanical lateral distal femoral angle and the medial proximal tibial angle is very, very important to be calculated, which roughly corresponds to about 90 degree. So what we do is we take we make the mechanical axis of femur, then mechanical axis of tibia like this, then draw two joint line congruence angle, then the angle subtended, this angle is lateral distal femoral angle, and this here corresponds to about 90 degree. And this is the medial proximal tibial angle, and this is in this picture, in this particular case, this is the problematic condition here. So LDFA is about 90 degree and MPTA is about 81 degree. Normal is 87 plus minus 3 degrees. So deforming bone, the problematic bone here is the tibia. So we plan accordingly. We plan opening wedge osteotomy, make the hinge point at the tip of the fibula, tip of the head of the fibula, and open accordingly. And this will be our new weight bearing line that passes through lateral point of the lateral tibial spine. So this is way how we plan, and this is new weight mechanical axis of tibia and femur. Okay. and MPT is corrected to 89 degree after doing this. So causes of deformity may be joint erosion, isolated joint erosion. The metaphyseal, the cause may be from metaphysis, or the cause may be sometimes from the ligamentous laxity, lateral ligaments laxity or medial ligament laxity. And sometimes the cause may be diaphyseal malalignment. So now, before planning correction, what we must know is when weight bearing line passes through center, what happens is almost 60% of weight is transmitted to medial compartment and about 40% weight is transmitted to the lateral compartment. When there is 4-degree valgus, what happens? The medial and lateral compartment are equally loaded, but to offload the medial compartment, almost about 6 degrees of valgus is required. By doing so, almost 60% of weight will be now transmitted to lateral compartment and 40% will be transmitted to medial compartment. Taking this into account, what happens is, this is the mechanical axis of femur and this is mechanical axis of tibia. We know that there is a varus of about 10 degree, and what we plan is, we plan about 6 degree of valgus, so that we can offload the medial compartment now. So this is 6-degree valgus planning, and so this line will now pass not from the center, slightly from the lateral side of the slightly from the lateral compartment. So this will be the new point of weight bearing line, and this is not, as we have seen, this is not through the center of the knee joint. This passes far more lateral than the center of the knee joint. So this concept gave rise to the Fujisawa point in 1979. According to Fujisawa, if to offload the medial compartment in medial compartment osteoarthritis, the new weight bearing line should not be passing through the center of the knee joint. Rather, it should be passed through about 30 to 40% lateral to the center of the knee joint. That point is called the Fujisawa point. And Jacob and Murphy in 1992 modified this point according to degree of osteoarthritis. According to them, if there is 1/3 loss of medial cartilage, then the new weight bearing line should be shifted 1/3 lateral to the lateral tibial spine. Then if there is 2/3 loss of medial cartilage, then it should be shifted 2/3 lateral to the lateral tibial spine. And if there is severe bone on bone disease and medial compartment cartilage is profoundly lost, then the new weight bearing line should be through the Fujisawa point. This was also further strengthened by this biomechanical study by Munta et al. And according to them, if the new weight bearing line is through the Fujisawa point, then there will be medial compartment offloading, and the weight will be transmitted to lateral compartment in almost about 60%. So this is how we plan correction. This is the mini-AC technique I will be discussing about. This is the same full length X-ray. There is varus in right knee. So this will be our new weight bearing line that passes through the lateral tibial spine. And this amount of angle will have to be corrected. And we choose the hinge point over the tip of the fibula and subtend that much of angle over the proximal tibia. So this will be our correction, and this is the corrected film. Now the weight bearing line has passed from the lateral tibial spine. So this is the mini-AC technique of correction, and Fujisawa has shown in his paper he did arthroscopic study of 54 knees of those patients where he did high tibial osteotomy up to the Fujisawa point, and he made 4 conclusions. That those are: ideal correction of mechanical axis alignment to 30 to 40% lateral to midpoint is ideal, and cartilage repair of ulcerated region was initiated by remaining cartilages if the alignment was proper. Then 1 or 2 years after the osteotomy, ulcerated cartilage was replaced by fibrocartilage, and ruptured meniscus also healed if the correction is ideal. So there has been multiple studies that shows the redo arthroscopy, re-arthroscopy was done after the high tibial osteotomy, and many of these papers claim that there is regeneration of the cartilage in the medial compartment where there was nothing, the cartilage was missing. And though this is not of the high quality hyaline cartilage, but fibrocartilage will regenerate, and there will be recartilization in these settings. So this has been shown in Fujisawa's paper as well. The upper one is the pre-operative or pre-high tibial osteotomy pictures of the same patient, and lower one is the regenerated cartilage, though regenerated cartilage in these particular knee joint after high tibial osteotomy. So final one to decide is the fixation option. There are two very popular fixation options these days. One is the Pudu plate, and another is Tomofix like plate, angle stable Tomofix plate. What we prefer is the Tomofix plate, because these are quite sturdy, they are quite strong, and there are multiple options in this Tomofix plate. And if hinge fracture do occur during surgery, which may occur during any type during intraoperative period of high tibial osteotomy, these Tomofix plate can be used as fixation options as well. So if has to be chosen in these two implants, the Tomofix plate is better according, and we are doing Tomofix plate fixation in our cases in AKB center. So the take home message is meticulous preoperative planning is key to successful surgery. As they say, failing to plan is planning to fail. So let's not plan to fail. Let's plan it and do successful surgery. Thank you so much from Team AKB Center. And
congratulations, Vivek, for the presentation and for your nominations as well. And you deserve the post for the nomination you've given, because you're one of the such a dynamic young surgeons, and we're looking forward to your success in the election. And you made this presentation very simple. You have simplified in such a beautiful way. I thought it was so complicated. And once I went through your presentation, you have made things so clear. And we were wondering in Chiton how we could get these scanograms. And that was a beautifully improvised way. I hope we are going to try that as well. Any questions in the chat box? Oh, well, I don't see any questions in the chat.
Add something. Hello? Can you hear me?
Yes, sir. Yes, sir. Yes, sir. Yes.
I just on Vivek, that is a lovely way to do it on the computer. But I just wanted to add in that you can do it the same way by printing it out and sticking it with tape. So a long time back, we used to do print 3 of them and then just stick it with tape and put it against a long. But you need a long view box, of course, to really go and measure it up.
Yes, sir. Yes, that can be done. Even these things can be traced on tracing papers, and accordingly, the osteotomies can be planned in tracing.
That is the old way that we used to do it. The second thing is about the Fujisawa point. Is that the only point everyone recommends? Because there is a lot of controversy about that too, isn't it?
No, sir, not exactly. Fujisawa, according to Fujisawa, the 30 to 40% lateral to lateral tibial spine is an ideal point of correction, so that there will be medial compartment, the offloading and cartilage regeneration is possible. But nowadays the trend is to have new weight-bearing line right through the base of the lateral tibial spine, not up to the Fujisawa spine. If the knee compartment osteoarthritis medial compartment is bone-on-bone disease, that is there is no cartilage at all, then we have to go up to the Fujisawa point. Otherwise, the best way is to correct at the base of the lateral tibial spine, lateral base of the lateral tibial spine.
The reason I said that is I've seen a osteotomy, the surgeon, this guy, he's taken the line through a 75% point. And he used to say if there's severe, then he used to do unicompartments and both of them. And so he says that you can take it up to 75. If there's very severe, then things can be modified according to the patient. So it is not, Fujisawa is a guiding point. That's what I would say.
Yes, sir. This is not an absolute point. According to the knee osteoarthritis, you can change this point. And the Murphy in 1992, as I've shown in my presentation, they have modified the future point according to the level of degeneration.
Thank you.
Vivek, one question for you. Do you recommend arthroscopic diagnostic arthroscopy before every HTO?
So this is very controversial. This particular question I asked during to our faculties during our past STO class. But what I think is, if you have facilities available, it's not it's always good to do arthroscopy and remove some mechanical things that are causing pain around the knee joint. But having said all those things, if you think there is medial compartment osteoarthritis, if patient is complaining the medial sided pain, and if you are pretty sure that this particular pain is because of medial compartment osteoarthritis, then I think arthroscopy is not the must before the high tibial osteotomy. And if you have no availability of arthroscopy, you can go on with high tibial osteotomy without pre-arthroscopy.
Vivek, one more. Is there anything that you think about? Because if you have a huge angle correction, then there's a lot of PFJ, increased pressure in the PFJ. So is there any point that you say that you have to do osteotomy of the tibial tuberosity also?
There are two types of high tibial osteotomy, mainly the opening wedge high tibial osteotomy. Those osteotomy which were done with the external fixators, and those osteotomy and external fixator, and then they do the gradual correction. Second one is you do all correction at once by open means and fix it with plates. So when doing osteotomy with the external fixators and doing the gradual correction, what they do is they do osteotomy below the level of tibial tuberosity. But when we do at once correction, that is above the level of tibial tuberosity, and we usually do the biplanar osteotomy, so that the whole of the proximal part of the tibia becomes free one, and the patellofemoral, the patella alta or patella baja won't be a problem after doing osteotomy. Having said all those, if you do the correction more than 14 degree by high tibial osteotomy, by any means, there will be problem with patellofemoral alignment. There may be patella baja, mainly patella baja. So I think if you restrict your angulation to less than 12 degree, and if you do biplanar osteotomy, if you are doing your osteotomy above tibial tuberosity, then there won't be any problems.
It's usually said about 12.5 millimeters of angle of millimeter of bone change that actually causes pressure to the PFJ. That's where the PFJ angle goes up. Yes. And other thing is also using Lobenhofer's osteotomy, isn't it?
Yes.
Do that, then the tibial tuberosity goes off. So a lot of people do, what I've seen is do a Lobenhofer osteotomy.
If osteotomy is done below the level of tibial tuberosity, there won't be any problems, sir. But the problem will arise if we do above the level of tibial tuberosity. But if we do biplanar osteotomy, by doing biplanar osteotomy, what happens is the proximal part of the tibia becomes a free bone. So until and unless the correction is very high, like you mentioned, more than 12 or up to 14, then there won't be issue with the PFJ. But if the correction is very high, which we usually do not do, because if that much of proximal tibia correction has to be done, I think the calculation or planning has been wrong in that very first instance, because distal femoral osteotomy will have to be added in such cases. So I think until and unless the correction is well below 12 degree and you are doing biplanar osteotomy above the tibial tuberosity, the PFJ problem will not be there, sir.
Thank you.
Well, Vivek, there is one question from Dr. Akash Porkel. He wants to ask you, what is the maximum correction that can be achieved?
See, Akash, there is maximum correction that can be achieved with high tibial osteotomy. Depends upon your calculation. So you have to measure, you have to plan in your long length X-ray, lower limb X-ray, and usually up to 12 or less degree of correction is done. In our AKB center, we have not done correction more than 10 millimeter, 10 degree, I think. So high level of correction will be, you will get lots of complications like PFJ complications we have just talked about. And usually those high level of correction are usually not required. And when you are when you get high level of correction, you have to rethink and replan all your planning. You have to revisit your planning, because such high level of correction do not occur. Because if those high level of correction is seen over there, I think in that cases the distal femoral osteotomy also has to be there, or there is some problem with the lateral joint congruence, joint line congruence angle, because these are not so usual.
I think, Vivek, if it goes, starts going around 15 degrees, then as you said, is distal femoral. The consultant which I used to have a look, his protocol was to shift to unicompartment knee replacements. And so that's what he used to actually divert. So unicompartment, there's a huge study coming up in Oxford now. And I think it is coming up in a very big way too with the new systems. So that is an option that we have to be also aware about.
So I must include one fact that if the correction is very high, maybe more than 12 or reaches up to 14, then what happens is usually we do high tibial osteotomy without any bone graft in between. So if the correction is very high, if more than 12, then bone graft also will be required in those cases. But I think they are very rare. We have very little experience.
Vivek,
yes, sir.
Can I add? Can I add a little bit?
Yeah.
So whenever you need a correction of more than 12 to 13 degree, then we have to reassess the patient again. So if you reassess and still identify that the required correction is more than 12 degree, then probably open wedge high tibial osteotomy alone is not enough. Either you have to supplement with the distal femoral osteotomy, or you have to plan some different procedure, like Sailas is saying. Probably the patient will be better with the unicompartmental replacement, or will be better with the dome osteotomy or other types of osteotomy. So that is what you have to do.
Yes, sir, absolutely.
Well, I don't see any more questions or comments from the participants and other seniors. Vivek, thank you once again. Now it's time to move on to another presentation by Professor Amit sir. I could see and assist a few high tibial osteotomies being performed at his expert hands during my fellowship. And now let's hear from the horse's mouth how the high tibial osteotomy is done. Amit sir.
Thank you very much, Sushil. My slide is visible, and am I audible?
Yes, sir.
Okay, so this is not horse. This is old horse now who is tired, and the young horses are now taking over, like Sushil and Vivek. This video of the high tibial osteotomy is prepared by Vivek himself. Since I have become a little lazy, I had other business, so Vivek helped me out to prepare this video. Number one, before I start, I would like to congratulate Arthroscopy Society of Nepal and confess that I have participated in so many HTO, webinars, talks, and live talks, and this is probably one of the best. And Sudeep sir so nicely described all those terminologies without which it is not possible to understand what the high tibial osteotomy is. Then Sushil and Vivek, they polished. And then my job is only to show how actually it is done in live. I must congratulate all my youngsters and Sudeep Man sir for having such a wonderful, and then Sailas for organizing, our scientific committee chairman for organizing such a wonderful webinar. Those who are not here, they simply missed one of the best webinar on high tibial osteotomy. So let us see this animation of the video of what is high tibial osteotomy. You give about 5 to 7 centimeter incision midway between the posterior and the anterior border of the tibia. People do with the horizontal incision also, but mine is a longitudinal incision. Then you do certain soft tissue procedure, which I'll show in my live surgery. You pass your K wires to guide your cut. Then, as Vivek was saying, it is important to do a biplanar cut. So this is a horizontal cut, and then you get an oblique cut. So this oblique cut is very, very important, and it has to go at about 120 degree, and it has to take the tibial tuberosity off. So this part is now free. So when you move this part, your tibial tuberosity doesn't actually move. Then you complete your osteotomy. Use various devices to distract to the desired length, so that your mucolis line passes through your desired part. You check intraoperatively, either it is going through the desired part or not. Then you use various types of plate. As Vivek said, we started with the Pudu plate, and now we are settling down with the this type of plate, which is a locking Tomofix type of plate. Then you fix your screws. All these has to be under the C-arm guidance. You get a lot of exposure of C-arm so that your screw passes on correct direction and they are of the correct size. And after that, you remove your distractors and you close your scheme on layers. So this was the simplified version of animation. I will talk about this 49-year-old lady who has been visiting, as Vivek said, multiple center with the both knee pain, actually, right pain more than the left one. And if you see her standing picture, you will see that the right knee is more on varus compared to the left knee, although she had problem on both the knee, but the right knee was the more bothersome. Over past few months, Vivek has been expert, so we'll just take pictures and send that to Vivek, and Vivek sends me this mucolis line, and which passes way beyond the medial joint line. Although if you see on the left side also, she had off alignment of her left knee as well, but she was more symptomatic on the left side. This is how she used to walk. There was important is to see that there was no valgus thrust on the knee. If there is a valgus thrust, there is a ligamentous that also has to be, taken care of. In this particular case, there was no valgus thrust. Another thing I would like to highlight that I always suggest to get an MRI done for all these patients because of various reasons. Number one reason is to assess the cartilage, not only of the medial compartment, but also to assess the cartilage of the lateral compartment. So what high tibial osteotomy or whatever osteotomy or realignment surgery does is it passes the load from diseased cartilage to the normal cartilage. So the diseased cartilage will produce certain pain. That is why we want to shift this weight bearing point from the diseased cartilage to the normal cartilage. That is why Sushil also mentioned that if the lateral side is also involved, the lateral side cartilage is also involved, the meniscus is not there, good meniscus is not there. Probably if you shift the weight bearing area from the medial to the diseased lateral side as well, it is not going to work for you. The pain is not going to reduce. So that is why it is important to assess the cartilage status by appropriate MRI cuts. The other thing important is to see the meniscus. If there is a flap tear, if someone is having mechanical locking, if there are loose bodies, so even after doing osteotomy, these mechanical symptoms may not disappear. That is why it is important to look at the meniscus, the status of the meniscus, to identify either there are loose bodies or not. Probably MRI is essential so that you can plan accordingly. If a patient is having mechanical symptom, loose bodies, flap tear of the meniscus, bucket handle tear of the meniscus, probably I'll go ahead with the arthroscopy first, treat those conditions as well, and then only I'll perform the high tibial osteotomy. This is another sagittal picture of the same patient, sagittal MRI of the same patient, just to see that the lateral side, the meniscus is normal. If you see the cartilage on the lateral side, this looks perfectly okay. But still, why I want to do an arthroscopy? is sensitivity of the cartilage in MRI is not very well established in our country. That is why I always do an arthroscopy and see that her lateral condyle or the cartilage of the lateral condyle is good enough to withstand the new weight that will be coming from the medial side after the high tibial osteotomy. So in this particular case, her lateral compartment looked pretty okay. There was a mucoid degeneration of the ACL. That is why she was having a little bit of impingement as well. So if she is having a mucoid degeneration of the ACL, again, I'll suggest to go arthroscopically, go do a decompression of these, mucoid degeneration of the ACL and plan your high tibial osteotomy. So if you compare the lateral compartment with the medial compartment, there are lots of osteophytes in the medial compartment and there are no osteophytes and practically pristine cartilage in the lateral compartment. This axial cut is again very important. Dr. Sailas, Dr. Bivek were talking about the patellofemoral arthritis. If a patient is having a patellofemoral arthritis associated with the medial compartment arthritis, probably a STO is not going to work because of the high tibial osteotomy, the patellofemoral pressure is going to increase. This is another reason why MRI has to be done and carefully read, and another reason why arthroscopy has to be done, and the status of the cartilage of the patella and the trochlea has to be assessed before you go ahead and embark onto the high tibial osteotomy. These are beautiful pictures and the angles identified using the Mikulich technique, Mikulich line, going not exactly through the Fujisawa point, but through the lateral tibial spine, and this angle was exactly 10 degrees. So we decided, we counseled the patient. Before going to the live surgery, counseling a patient for high tibial osteotomy is really, really difficult because when you say that we have to break your bone, we have to align your bone and then put a plate so that we can, this fractured or broken bone gets healed. The patient very often, they do not take it lightly, and probably this is one of the reasons why high tibial osteotomy is not very accepted by many of the patients. But going to the literature and learning the experience of people who are doing high tibial osteotomy so often, and our experience of last 5 years of doing high tibial osteotomy, we just fell into love with this procedure, and we nowadays we do it very often. Long incision midway between the anterior shin and the posterior part of the tibia. So you go gradually, right up to the sartorial fascia. So when you release the soft tissue, you reach to the sartorial fascia. Then you hold the sartorial fascia and identify the hamstring tendon, lift this hamstring tendon with a L incision that we usually do while harvesting a hamstring graft in doing a various ligament reconstruction. So this is a horizontal incision, which is now being supplemented by a longitudinal incision. So that is your L incision. This was horizontal and then longitudinal. So this will lift the whole of the sartorial fascia and your MCL will be visible. So this is lifting of the sartorial fascia. So you release this right from the attachment of the hamstring. And then you see that the glittery underneath part is the MCL. So now underneath the sartorial fascia, identify the posterior edge of the tibia. So this process is very important. Many a time when you do a high tibial osteotomy with a patient with varus, there is a contracture of the MCL. So if you do a high tibial osteotomy, there will be more pressure on the MCL. So nowadays it is suggested to completely release the MCL. So if you see here with a horizontal and a longitudinal incision, the MCL was completely released. Then underneath the MCL with the subperiosteal dissection, you gradually go towards the lateral side and reach to the head of the fibula. So once the posterior dissection has been done, then you mark your osteotomy. So this is osteotomy on the sagittal plane. This is osteotomy on your horizontal plane. So once the osteotomy site, which is about 4 centimeters below the joint line, is marked, then you pass your marking K-wire to marking K-wire, which goes right above the tip of the fibula so that it avoids the tib-fib joint. Nowadays, we put a hinge wire, some put hinge screw to prevent the hinge fracture. So this was the hinge screw is being placed and then give a horizontal incision. So this is a, horizontal horizontal osteotomy. So this goes axial osteotomy. This has to go right up to the hinge point, which is about 1 centimeter away from the lateral edge of the tibia. So once this horizontal osteotomy is done, then you give a sagittal osteotomy, tibial spine. Then you use osteotomes, various sizes osteotome, so that you complete your osteotomy both anteriorly and the posteriorly. So once you complete your osteotomy, especially posteriorly, your osteotomy sites opens a bit. Now you confirm your opening with the high tibial osteotomy distractor jig. This is of Arthrex. So you distract as it is required, and the angle is measured with this one. There are other devices also that can be used, but this is the one that we very commonly use to gradually open the osteotomy. Once the desired opening is achieved, then we use a cautery wire to confirm our correction is good or not. So this is the center of the hip, this is the center of the ankle, and then we take a CM image of the knee, in which you see that this is just going
Something wrong with Amit sir's internet, I think, Vivek?
I think so. So there is problem with his internet connection. He'll be back soon. So by the time we can take some questions, I think if seniors and colleagues, you have any questions, please, you can ask it.
Hello. Hello.
Hazur sir, Hazur.
Vivek, what are the measures that you take to avoid the posterior vascular structure of the knee,
sir,
and to avoid the fracture of the tibial tuberosity when you do the oblique cut? Hello, can you hear me?
Yes, sir. Sudeep sir, please go ahead, sir.
Did you get my question?
Sir, I was talking to Amit sir. Can you come again, sir?
And what are the measures you take to prevent the damage of the posterior vascular structure when you do the transfer cut, and to avoid the fracture of the tibial tuberosity when you do the oblique cut of the tibial tuberosity, around the tibial tuberosity?
That is wonderful question, sir. I must say, in first few cases, there was intraoperative. We had so much of palpitation, because as the osteotome moves around, it has some it translate posteriorly and anteriorly, and the popliteal artery is right behind there. So what we do nowadays is we release posteriorly, subperiosteally, all the way up to the tibiofibular joint from the medial side. Medial to lateral, whole of the posterior part, the posterior popliteus muscle is released and only bone is exposed in the posterior part. After doing that, we keep a broad humen right posterior, right at the posterior part where the osteotomy will be done. So after that, once we are sure that the area is well secured, the posterior soft tissues are well retracted, only then we do the osteotomy. I think that is the way.
Vivek, I'm back. If
yes,
you can
yes.
make me co-host, I'll again share my screen.
Okay, sir. Sure, sir.
So where was I actually? The internet is so poor today.
We were using that Zig to open the osteotomy site, sir.
Okay, I'll start from there. Okay, so is my screen visible, Vivek, now?
Yes, sir, yes.
Okay, so this is how, we use a device to open the osteotomy site. So this is of Arthrex. We have a locally made also available. So once you open to the desired angle, so this will give a measurement of the angle also. So once you open it up to the 10 degree, then you use your C-arm and then confirm, put your, this is the wire of cautery, put at the center of the hip and then center of the ankle. So once you put it in both the place, it has to go through the correct point. So now after 10 degree of opening, it is going through the lateral compartment. So then you use a lamina retractor to maintain that reduction or maintain that opening. Then you use a tomofix plate. So it is important to maintain the opening by using a lamina retractor. Also to maintain the posterior opening. So it will not be a parallel opening, but it will be a trapezoid. If you understand the anatomy of the proximal tibia, so opening should not be parallel. If opening is parallel, then you are disturbing the posterior slope, which is not very much desirable. So once confirmed with that, I put a K wire on the proximal part, again under the C-arm guidance, so that my plate doesn't migrate proximally or distally. Then I first fix distally 1 or 2 screw on the distal fragment. Then again, under the C-arm guidance, I pass the cancellous screw of desired length on the proximal side. While doing so, you just give a tuck into the MCL, the proximal fragment of the MCL. However, you do not repair that. And this is how C-arm looks like after removal of the hinge wire. And this is at the end of the surgery. So what I would like to mention that, and this is the post-op X-ray of the same patient. This was the very recently done. I'm not able to show her good outcome yet, but definitely in the further meetings, we will definitely share the outcome of the HTOs as well. So one thing I'd like to highlight that a C-arm is a must. Your positioning of the C-arm is a must. This is all C-arm assisted procedure. So without C-arm, you cannot do this procedure. So rehabilitation is important. Again, there are controversy on rehabilitation, when to start weight bearing. I'll not go into detail of that, but early range of motion is very, very important. So range of motion should be started as soon as possible and achieve full range of motion by 4 weeks. So full range of motion has to be achieved by 4 weeks. Usually we advise non-weight bearing crutch walk for 6 weeks, but this was truly applied for Puddu plate, and it is considered that Puddu plate was not stable enough to allow weight bearing. And there are surgeons who allow weight bearing in 2 weeks time if they have used a very well tomofix and there is no hinge break on the lateral side. So what we do in our practice is non-weight bearing on crutch walk for 6 weeks, and from 6 to 8 weeks, we gradually go into partial to full weight bearing. Again, I'd like to thank Arthroscopy Society of Nepal and Team Scientific Committee for giving me this opportunity to share our experience. Thank you very much.
Thank you, Amit sir, for such wonderful demonstration of the procedure. Sushil, are there any questions in chat box?
Yes, Vivek. I can see a few questions here from. Okay, there is one question from here, Dr. Buddhi. How to assess triplanar correction of deformity during surgery?
I think this is a very important question, and at this moment, many people are talking about this, how to assess the triplanar correction. There are so many methods that has been described. You know, you put K wires in all the three planes. That is one of the technique that very commonly used to done is put K wires in both coronal as well as in the sagittal plane, so that this acts as a reference to your, further or future correction. So that is one of the technique that we have been using. Other technique is doing, image all the time. So all the time you have to do image and then, use your correction. When you do a open wedge, make sure that you take a lateral view also so that your slope is also corrected. So probably putting your K-wire, using your C-arm to have a look at proper correction is the way to go, I think.
But there is another question from Buddhidai as well. He wants to know, when is bone graft necessary in osteotomy site?
This is again a very important question. When the bone graft is necessary, many a time bone graft is not required if the opening is up to 1 centimeter. The bone graft is indicated if opening is more than 1 centimeter, or if there is a fracture on the lateral hinge, probably a bone graft may be required. Otherwise, most of the time, bone graft is not required.
Thank you, Amit sir. One more question from Dr. Manoj. He wants to ask, is there any role of correcting posterior tibial slope in HTO?
So HTO per se is basically to correct the varus alignment. But the subsequent experience of HTO has shown that if you can correct along with the varus valgus alignment, you can correct little bit of sagittal alignment as well, which may be very, very essential when you are correcting or when you are treating chronic ACL or chronic PCL deficient knee. So current literature, they say that probably in a very old case of ACL and PCL, rather than ligament reconstruction, probably just by correcting the slope, anterior-posterior slope, you can manage this ACL as well as PCL injuries.
So there was a question Sudeep sir asked when you were offline, sir. He asked how to prevent the injury to tibial tuberosity while doing the horizontal osteotomy during our procedure.
So tibial tuberosity, preventing tibial tuberosity. So you plan your oblique cut about 1 centimeter posterior to the tibial tuberosity. Then you mark the patellar tendon. Actually, it is not tibial tuberosity which is damaged. You mark the patellar tendon. Sometimes if you are too oblique, you can damage the patellar tendon. So you mark the patellar tendon, identify the patellar tendon, retract the patellar tendon, and be 1 centimeter posterior, and be just horizontal to the bed, so that you have a horizontal cut of that one.
Dr. Vivek?
Yes.
Yeah, I have addition to that. I have two more technical questions to Dr. Amit. How do you manage if your hinge is fractured, and if your osteotomy line crosses if there is a fracture of the articular surface during your procedure? Have you come across this problem? Because these are one of the known complications during the HTO. So if the hinge is fractured or your fracture line, if there is a fracture and it reaches the articular surface, how do you manage on table?
Absolutely, Dai. There is a classification given for this hinge fracture. There are 3 types of hinge fracture. The type 1 in which when it goes downwards. So your oblique incision that go downwards. This is a very stable fracture. You don't need to do anything to that. If it is type 2 fracture in which you have a transverse, that is called the osteomatization. So osteotomy has been done through and through. In that case, earlier people used to put, people used to put a staple on the lateral side, open into the lateral side, and they put a staple on the lateral side. But with the invention of these current type of fixed angle plate, like tomofix types of plate, these fractures can also be managed without opening on the lateral side by fixing the tomofix. The problematic is when you have a fracture extended to the joint, which is really problematic. In that case, probably you have to open from the lateral side and do a formal fixation of the lateral part as well.
So does your rehabilitation plan changes if you come across these fractures?
Absolutely. Since there is a complete fracture, so what we have to understand that the stability of high tibial osteotomy was given by the lateral hinge, considering that your lateral cortex is not violated. So if your lateral cortex is violated, your fracture has to be stable enough by the tomofix using adequate size and adequate number of screw. And it is suggested that your rehabilitation has to be delayed. But our practice, Sudip Dai, we have been doing a delayed rehabilitation to our patient. So practically doesn't change. But for those who do early rehabilitation, like weight bearing in 2 weeks time, in that case, probably you delay your rehabilitation.
Yeah, thank you.
There is another question in chat box. Is there a laxity of ACL or PCL after normal high tibial osteotomy? This is from Dr. Buddhi. Sir, you are muted, sir. Okay, it actually doesn't change. It doesn't cause laxity of ACL or PCL. I think Dr. Buddhi was asking, is there laxity of ACL or PCL after high tibial osteotomy? Was that the question? Yes, sir. No, because the femoral and the tibial, the distal femoral and the proximal tibial alignment remains the same. It is only the distal alignment is altered. There will be no change in the strength or the stretching of the ACL and PCL. Yes, sir. I can see Rajiv sir.
It's 11 hours.
Class. So, Rajiv sir, please kindly share your experience in high tibial osteotomy as you have been. Rajiv sir, please come in. Okay, I think there is some problem with his internet. So, Sushil, are there any other questions? Sushil?
Hello?
Yes, Sushil.
Yes, Vivek.
Any more questions?
No more questions, Vivek.
Okay, then we already, it's already 11 a.m. It was nice 2 hours discussion. So I'd like to request our president, Dr. Ishwar Pradhan sir, to have a concluding remarks.
Thank you, Vivek. I think we had a very nice, lively 2 hours discussion in this cold, crispy morning. It was very nice to get together after a long time. About the subject, high tibial osteotomy has come out in a very big way nowadays, and as it was already said that this technique is not a new technique. It had been done from early, 19th century, but the indications have changed. More so in our country now, the indication, because I'm sorry to say this to the arthroplasty surgeon, the arthroplasty surgeons are doing arthroplasty in more younger patients, even in our country, because of the terrain or the lifestyle. We have young people with osteoarthritis, and doing arthroplasty at a young stage is And it may be right, but there are reports, I read a report in one of my presentation for our class in BNB that Mohit Bhandari had done a wide, cohort study. It was a registry in Canada, and the results of arthroplasty in less than 60 years is that they have a chance of having a revision arthroplasty of nearly 30 to 35% in comparison of doing arthroplasty after they are above the age of 70. So like Vivek said, arthroplasty is one-time surgery, revision surgery does not have a good role. So especially in our country, when we have young patient, osteoarthritis in 40 years, this may have a very vital role, tibial osteotomy to correct the deformity. And it was very nicely shown by Vivek in studies done in Japan, like even KL grading type 3, where even, getting their cartilages regenerated after tibial osteotomy. So indication of HTO is one. And then there is this, some talks, people asking about, laxity correction in chronic ligament injuries with deformities. I think this is a different chapter, different topic, but this also seems to be coming up, the slope correction osteotomies. What I want to say is this is a very complex topic, but it needs to be done, and everything can be done in a very simplified way if you can approach the problem in stepwise pattern, like it was shown here, what are the ideal indications of doing STO, very nicely shown by our speakers, identifying the deformities, very nicely shown by our senior colleague, Dr. Sudeep. You should know the normal anatomy, and then only you can know the abnormal anatomy, and identifying these deformities with all those angles, these are brain racking angles, given by our famous drawer Pele. He was a genius, but he had his own problems also. So indication for STO, identifying the deformities, and then planning the surgery is also a big topic, which was very nicely shown by Vivek, as well as Sushil talked about that also a lot, the types of osteotomies, opening or closing. I just wanted to say, like the opening tibial, medial opening tibial osteotomy has come back in a big way, but there are still people, out in the world, and we met one of those who are still vehement to do lateral closing Wedge osteotomy, and they say that it doesn't hamper the long-term outcome. There are people also, maybe they have had good experience in their lifetime and they're still continuing with that. Choosing the right HTO, that is what I meant. And lastly, a brilliant presentation by my colleague, Dr. Amit, So we started with osteotomy after his, no, we were doing lateral closing with osteotomy, but at BNB, but the new turn, new tide of tibial osteotomy, which definitely has more advantages, more indications in, and this has been a routine procedure in our center, and now we have younger guys taking that over. So lastly, I want to thank everybody, all the participants, coming early morning today. And I saw Dr. Bulan Thapa somewhere also here, Good, welcome, sir. It was very nice to have you there with us. I think he has already left, or I don't know, but he was here for a moment. And thank you all the speakers. I feel sorry that we had to kind of postpone this webinar for some time, and the current situation, COVID situation in the Western world, in the US or in Europe seems to be coming back, second wave. But in Nepal, nobody gives.
I know.
Of the situation, we were trying to get back to our, normal routine. So we were busy, and we kind of lacked this on webinars, academic. But I think like this is a good part that even we can't get together in a real situation, but we must continue these webinars, maybe at least, once in twice a month that we used to have, the two monthly meeting of our academic meeting of our. So besides that, I think we had a good discussion. Thank you, Sailas, as the scientific committee chairman. Everybody was busy, like like I said, even in the West, the thing is coming back, but for us, we don't give a, we don't care about it, and we have to go back to work. I think we'll have more academic sessions. I think with that, thanking all of you, all the participants, all these nice speakers, I say I bid farewell. We hope to meet again very soon. We will let you know. Thank you very much.
Yeah, thank you very much.
Thank you. Thank you, sir.
Thank you. Bye-bye. Bye-bye.